Hi and welcome back to another video of Medic Notes. This video is on investigations of gastric carcinoma. The three main aims of the investigation are to establish the diagnosis, to stage the tumor, and supportive investigation to assess for complications of the gastric cancer. To establish diagnosis, we can do OGDS and biopsy. Assessment of tumor, assess its location, size, morphology, extent, and classify it using Borman classification. Assess for any complications, like tumor bleeding, tumor causing obstruction. Assess for any Helicobacter pylori infection, using CLO test. Allow for biopsies of suspicious lesions, biopsy the edges or margins of the ulcers, at least 6 to 8 bites. Advancement in OGD, magnifying OGD with narrowband imaging. Signs of early gastric CA with NBI include irregular microvascular pattern, irregular microsurface pattern, well-demarcated border. Other investigations are barium swallow. This is non-invasive but limited diagnostic value as it is unable to perform histological assessment. Useful for linitis plastica, where we look for reduced distensibility and leather flask appearance. Histology, to confirm adenocarcinoma by using Lauren classification. Or non-adenocarcinoma tumors, tumor differentiation, and can also assess for HER2 overexpression. Next, for staging investigations. Computer tomography with gastric protocol. CT performed with oral ingestion of effervescent granules, for gastric distension. This is accurate for T staging but limited in detecting organ invasion. There is also difficulty in differentiating between inflammatory adhesions with fibrosis, edema, or tumor invasion. Limited accuracy for end staging, small nodes may contain metastatic disease. Limited accuracy for assessing distant metastasis, but good for assessing hematogenous spread to distant organs, but limited value in detecting translomic spread and presence of peritoneal seeding. Can have a role in detect metastatic disease in the form of malignant ascites but not always accurate. CT thorax is important for gastric cardia tumor. Endoscopic ultrasound, useful in early stage gastric cancer. Superior to CT in delineating depth of tumor invasion, gold standard for T staging, and identifying perigastric and celiac lymphadenopathy in end staging. Depth of tumor invasion, T staging, is an important prognostic factor. Addition of FNA for suspicious node increases accuracy to around 100%. Positron emission tomography, PET scan, combines spatial resolution of CT with contrast resolution of PET, but its role is not established in gastric cancer. Staging laparoscopy can detect radiologically occult peritoneal metastasis. Routine use can detect small volume peritoneal and liver metastasis in 20 to 30% of patients believed to have local regional disease. Risk factors include patients with GEJ lesions, diffuse gastric tumor, poorly differentiated cancer, age younger than 70, patients with preoperative imaging that revealed lymphadenopathy more than 1 cm, and T3 or T4 tumor. Peritoneal cytology. Positive peritoneal lavage indicates independent poor prognostic factor. Lastly, there are also investigations to assess for complications. Full blood count, look at Hb level to look for iron deficiency anemia. Electrolytes, as gastric outlet obstruction may cause biochemical abnormalities. And liver function test, look at the albumin as a marker of nutritional status. It is unlikely to get deranged LFT unless widespread liver metastasis. That's all for this video. Thank you.